Now, of relevance to today's show is goal number 3, which is a 15-year target of ending the TB epidemic by 2030. Here at home, one of the long-term goals of the NDP, or Vision 2030, is to progressively improve TB prevention and cure. Then the world descended on Cape Town for the 46th Union World Conference on Lung Health, held between the 2nd and 6th of December 2015. Now, the conference theme was A New Agenda, Lung Health Beyond 2015. So today then we focus on TB. We have a range of experts who took part in this historic conference to just give us a glimpse on how the world, and especially sub-Saharan Africa, can end the TB epidemic by 2030. So sit back, relax, and learn from this exciting show ahead. You can interact with us on our Facebook page, SABC Health Talk, and on Twitter at SABC Health Talk. I'm Dr. Sello Mutaung, and this is Health Talk.
The son of Africa, Trevor Noah, is leaving America in stitches.
I never dreamed that I would one day have, well, two things really. An indoor toilet and a job as host of The Daily Show.
We are the first to bring you the latest films around the globe.
Dear white people, the minimum requirement of black friends needed to not seem racist has just been raised to 2.
Cobhams Asako is a gifted blind musician, a master of soothing notes from the piano.
I love to sit behind the piano. You know, that also helps me find inspiration.
Join Refilo Mulwa every Friday for that 1-hour weekly dose of art and entertainment news at 9 p.m. on Trends.
TB remains one of the main causes of death, especially for people living with HIV. TB and HIV co-infection is when one has both HIV infection and also active TB disease. People living with HIV are at high risk of developing TB because of their weakened immune system. HIV and TB co-infection is regarded as a dangerous combination, with each disease speeding up progress of the other. When a person contracts TB, they can recover fully when it is detected on time and if the patient sticks to treatment. Although there is no cure for HIV/AIDS, it can be managed through ARV treatment. This means that people don't have to die of TB and HIV co-infection. 6.8 million people are infected with HIV in South Africa, and it is the biggest number of people living with the disease in the world. A report released by World Health Organization shows that out of 500,000 incident cases in South Africa, 330,000 people are living with both TB and HIV. In 2014, 9.6 million people developed TB globally. 1.2 million of them were HIV positive. 74% of people who are infected with both TB and HIV live in Africa. If you have TB and you are also HIV positive, your health will improve if you take both TB and HIV treatment. Health Minister Dr. Aaron Motsoaledi has emphasized the significance of improving TB treatment to address the impact of TB/HIV co-infection. In addition to address co-infection, the National Strategic Plan for 2012 to 2016 focuses more on the prevention of new HIV and TB infections by 50%.
Right, so we all know that the Southern African sub-region is the epicenter of the HIV epidemic, and it's not surprising to note, therefore, that HIV is driving the TB epidemic in South Africa, with a TB/HIV co-infection rate of above 60%. It's therefore not possible to win the war against TB unless we win the war against HIV. Now, let's learn more about this TB/HIV co-infection problem from our special guests. First up is Professor Gavin Churchill, who's the founder and CEO of the Oram Institute based in Johannesburg. Welcome to Health Talk, Prof.
Thank you very much, sir.
All right, and we also have with us Dr. Lindiwe Mvusi. Dr. Lindiwe Mvusi is Director, TB Control and Management Cluster within the National Department of Health. Welcome to Health Talk.
Thank you for having me.
Mvosi. Now, perhaps let's start with you, Prof. I mean, we've seen the horrific co-infection rates of TB, HIV. Just in simple terms, what are the reasons, why should we have this co-infection between TB and HIV?
So HIV increases the risk of developing tuberculosis. So your risk in a high transmission setting is about 5-6-fold higher than someone who is HIV uninfected. But compared to countries where there is a low HIV prevalence, the risk of developing TB is actually 30-fold higher. So it's substantially higher if you're HIV infected. And so it fuels the epidemic. We've seen an increase in the case rates of tuberculosis in South Africa and across the region, sub-Saharan African region. But the good news is that despite this now, we're getting on top of it, and we are seeing declines in all sub-Saharan African countries, including South Africa.
Right. Okay, I know we're talking TB, HIV co-infection, but you mentioned that it's because of the depression in immunity that puts people at high risk. But are there other conditions, like for instance diabetes? Do we see a similar problem with conditions like diabetes?
Yes, so absolutely. Other conditions predisposed to tuberculosis, and these include diabetes, particularly if uncontrolled. And in the developing countries, the prevalence of type 2 diabetes, which is associated with obesity, is fairly high. In South Africa, it's about 8%. And over the next 20 years, the greatest growth in diabetes cases linked largely due to obesity is going to occur in sub-Saharan Africa, where we expect the prevalence of diabetes to double in that period of time. If you have diabetes, your risk of developing tuberculosis is about 3-fold higher. And so because the prevalence of diabetes is going to become higher than the prevalence of HIV, and diabetes in turn is a strong risk factor for TB, diabetes is going to be the next big thing we're going to have to address. We can't just worry about HIV, we're going to have to worry about HIV, the obesity issues linked to diabetes,
I would
to
imagine
attack the
risk could be worse than if you have both diabetes and HIV.
Correct. Yeah. So the risk would then be, there would be a combination of risks which would increase your risk of developing TB.
Right. Dr. Mvusi, we're talking here about TB, HIV co-infection. And there's talk that TB affects the poor, the marginalized, and so on. What are those vulnerable populations for this TB, HIV co-infection, at least in South Africa?
Well, first of all, you find that poverty is an overall risk factor on its own. And we find that in most cases, we will diagnose TB, treat those patients, they go back to the very same conditions that they live in, and will come back again because they will acquire TB again. And as a result, we find more people with relapses, and it becomes worse, obviously, with HIV as well. So much as we try and treat the diseases, we also need to address the socio-economic factors in which people find themselves in. But the people most at risk generally would be the HIV positive people, as it was said earlier. But then we also need to focus on children. We haven't really focused on children that much previously, but those are also at high risk of getting TB, especially when it's associated with malnutrition. We also find that for people who abuse alcohol, because they also do not eat that well, they have an increased risk as well of getting TB. Overcrowding in those situations as well encourages transmission of TB in the settings where there's informal housing with poor ventilation.
What are the problems then associated with treating either TB or HIV where these coexist? So
the drugs, when you have to use them in combination, may have drug-drug interactions or overlapping toxicities. And so there are certain of the TB drugs which make it more challenging to use with some of the antiretroviral therapy, for instance. And so there are certain drugs we may have to avoid or adjust the dosage of those drugs so that we can use them in combinations. But today we have both antiretroviral therapy regimens and our TB regimens, where certainly for the first line of TB treatment, we can treat both very adequately with very good long-term outcomes. For multi-drug resistant TB, it becomes more challenging, but even there we can find a way of treating appropriately so that people can have both diseases treated properly.
Okay. I know with HIV, in terms of compliance to treatment, we seem to be doing quite well. But how are we doing with TB? Are there compliance issues, stigma issues, perhaps, at least in those that are HIV positive?
Yes, adherence is a problem generally with TB, but we're seeing it now even on patients on ART, where the rates of loss to follow-up are increasing. But to try and address that, we're now looking at the interventions to continuously counsel, encourage patients to continue taking their treatment. But the other thing that we find is that at the end of the day, in some of the TB patients, taking TB treatment is the last thing on their priority list. So addressing the other factors that the patient might be facing at that time is critical. For example, stigma is a huge problem. And we need to try and focus on how we mitigate stigma. We need to also try and focus on how we improve social protection and support for patients overall, and ensure that they have access to food security, they have access to employment opportunities or skills development so that they can generate income.
All right, just hold it there because we're going to just need to go for a quick commercial break. And after the break, we now learn more about the problem of TB in prisons. Please stay with us.
The son of Africa, Trevor Noah, is leaving America in stitches.
I never dreamed that I would one day have, well, two things really. An indoor toilet and a job as host of The Daily Show.
We are the first to bring you the latest films around the globe.
Dear white people, the minimum requirement of black friends needed to not seem racist has just been raised to 2.
Cobham's Asako is a gifted blind musician, a master of soothing notes from the piano.
I love to sit behind the piano. That also helps me find inspiration.
Join Refilo Mulwa every Friday for that 1-hour weekly dose of art and entertainment news at 9 p.m. on Trends.
South Africa is one of the countries with the highest burden of TB, with the World Health Organization statistics giving an estimated incidence of 450,000 cases of active TB in 2013. According to the World Health Organization, South Africa ranks the 3rd highest in the world in terms of TB burden, especially in prisons. Poor ventilation and overcrowding are the causes of TB prevalence in prisons. According to the National Department of Health, South Africa's prisons have recorded high rates of reported TB cases. The inmates population was on average 160,000 in 2012. There were 6,197 reported inmates with TB, which gives a crude prevalence of about 4%, higher than 0.7% in general population. The Department of Health introduced 2 interventions which were intended to find as many, if not all, TB cases to put on treatment and reduce the risk of infection in the community and prisons. By screening and testing people for TB, especially those who are in contact with people known to have TB. The introduction of a much more sensitive or strong detection ability called the GeneXpect, which gives results within 2 hours compared to days or weeks using microscopy technology.
now we are saying don't wait for anybody to be sick. As long as you are going to be inmate, you must be screened on entry. Secondly, during your period of incarceration, you must be screened at least twice. So these are not sick people, they are just those who screen. And then when you get discharged, when you exit before going home, we screen you so that you shouldn't take your TB home with you. That's one of the things that we are doing.
Launched in 2012, the National Strategic Plan for HIV and AIDS, Sexually Transmitted Infections and TB for 2012 to 2016, the country has prioritized the need for innovative research into the new TB drugs, diagnostics and vaccine development, which the government is currently funding.
We've done an amazing amount of work. Things have really improved in Portsmouth. We've doubled TB case finding. And in just a period of 1 year, we were able to double the TB case finding. So now, in the last 29 months, we've diagnosed 915 cases of TB. And if you estimate one case could infect 20 others, then we have potentially prevented 18,300 cases of TB just through our interventions.
Okay, now to help us unpack this challenge of TB in prisons, we welcome back our special guests. We still have Professor Gavin Churchyard, founder and CEO of the Oram Institute, and Dr. Lindiwe Mvusi, Director, TB Control and Management Cluster, National Department of Health. Now, clearly in prisons, I mean, you know, we have people that are in a confined space. They're there, you know, they are easily accessible. Why is TB a problem in prisons?
So tuberculosis is common amongst people entering prisons. It tends to be commoner than in the general population.
Yeah.
And then we have two groups of prisoners we need to worry about, those that are awaiting trial and those that are incarcerated. And those that are awaiting trial, often they wait for long periods and often have difficulty accessing care, and they have significant overcrowding.
So accessing care when they're
waiting trial. Yeah.
Okay.
And so trying to get people in that are incarcerated into care is a challenge. And so as we heard in the clip, the minister saying that we need to put in place the screening program, and mine and other groups have been instrumental in rolling out the screening program in prisons, is one of the key steps we need to take to deal with the problem. But the prisons actually they accentuate the TB problem, so they amplify it and may also contribute to the spread of TB in the surrounding community. So
yeah, but I'm going to ask you why, you know, this is amplified, but maybe just going back to what you said earlier, that the prevalence seems to be higher in those entering prisons as compared to the general population. Why should that be?
Because people are coming from poor backgrounds often, and the access to care is different.
Yeah.
And so there are many factors that contribute to that, but probably socioeconomic status is one of the most important of them.
Yeah. Could it, Dr. Mvusi, could it also be that, you know, it's people that are defined? I mean, we are able to screen them better as compared to the general population, perhaps? Your thoughts?
Well, the prisons, the settings, they are such that, as it was indicated, it's concentrated in terms of poor ventilation and overcrowding.
Yeah.
So you find that people come in to the prisons with TB and therefore infect others within that setting. And again, you might find that people with TB remain undiagnosed in prisons and go back to the communities on discharge, or if, on discharge mainly, with TB, and continue to infect people in the communities as well. That's why we have to ensure that when they come in, we screen, and regularly, annually, we screen at least twice a year. And when they go out, we screen them again so that we can pick up those that have TB, ensure that they start their treatment.
Earlier we spoke about HIV. So do we screen them for both HIV and TB? And is it voluntary?
Yes, we screen them for both. It is voluntary, even in the correctional facilities. And we need to then ensure that if they have TB, they are started on treatment early, and we monitor them closely whilst they are on treatment. There are challenges that are specific to these facilities in that at any time, a person can be transferred from one facility to another. Therefore, we need to have measures in place that patients do get their treatment wherever they go within the correctional facilities. And again, for the awaiting trial, they might be started on treatment, go to court, discharged back home. We need to put measures in place that when they are discharged in that manner, they still access treatment when they go back to their homes.
Okay. I mean, clearly, before we can start treatment, we must find the cases. Now, do we have an idea in terms of how many of them, in those that we screen, how many do we end up, picking up TB?
So the proportion of prisoners that have TB is fairly high. So it varies from prison to prison, of course, and by country. But in South Africa, we've documented a prevalence of about 3.5%. And that compares with, in the general population, we're uncertain because we're still about to start the National Prevalence Survey, but on small studies that have been done in South Africa, that would probably be about 0.7, 0.8%. So it's substantially higher amongst prisoners.
Okay, let's talk about treatment now. I mean, what, at least in those that we've, picked up with TB, with or without HIV, are there any challenges around treating these prisoners?
Not really, because now treatment is available within the correctional facilities, so they can access treatment. And they are encouraged by peer educators to continue taking their treatment within the facilities. There is support that they are getting from both healthcare workers and peer educators. The only challenge is ensuring that they continue treatment as they move either back to their communities or within the facilities, correctional facilities. And within correctional facilities, the challenge is the security issues, because health and security are completely different. So health will never know when a person is transferred to another correctional facilities. But it's up to the patient then to request or inform the healthcare workers that they were on this treatment and they need to continue with that. What we need to do is to try and strengthen the referral systems as the patients move.
Prof. Churchyard referred to earlier about the problem of access to healthcare, especially in the awaiting trial prisoners. What is the problem there, and what is the department doing about that?
Well, initially it wasn't clear in terms of who is responsible for providing those services to those awaiting trial prisoners, but I think those issues have been resolved. The awaiting trial prisoners are actually able to access. They are part of the group that is screened when they get to the facilities and tested, and if they are found to have TB, they can access treatment. Again, the challenges are that depending on the duration of stay in the facilities, they can leave at any time. So it's up to the patient again to and make the point of getting to the nearest facility when they get back home and continue with the treatment.
I guess it's a bit of a difficulty. When they leave prisons, they live with their condition and their treatment. And it can only be hoped that, when they get to their communities, they then are able to access services.
Yes, but we're also trying to strengthen the link between the district and the facilities, the correctional facilities there, so that they could communicate and inform each other of such patients.
All right. Okay. So why do we have treatment failures and resistance to TB medication in some individuals? Well, more on that after the break. Please stay with us.
We live in a digital era, and the number of Africans with mobile phones is rapidly increasing.
Twitter use is predominantly being done on smartphones. This is a very African phenomenon.
Here, there are constantly new innovative ways to make the internet more affordable. With that, we're seeing protests against governments proposing methods to limit access. On Network, we give you information about all of this. We also have new computers, games, and robots.
Join Siphumelele Zondi on Network every Sunday at 19:30 CAT.
Makamelo Sekhontse, one strong woman who said no to hunger. She never allowed circumstances to pull her down. At daybreak, she is up and running in the streets of Johannesburg to make her living. After 12 hours of hard work, she goes back home being able to put food on the table. Join me, Bulemo Lebatsi, on your show about those who take on and conquer life challenges every Saturday at 5:30.
Welcome back to Health Talk. Today we're discussing TB. Now, if we're ever to have hopes of eradicating TB, we must achieve 100% success in treating those that have been diagnosed. Now, to learn more about this and all related challenges to TB treatment, we still have Professor Gavin Churchill, founder and CEO of the Oram Institute, and we now welcome Dr. Nobet Njeka. Dr. Njeka is Director Drug-Resistant TB and HIV within the National Department of Health. Welcome to Health Talk, Dr. Njeka.
Thank you.
All right, maybe let's start with you. We're talking about TB treatment. We're not going to talk about how TB is treated, because I think that's fairly known. But maybe you can just give us in 10 seconds how normal TB is treated, and then we get on to resistance to TB. But before that, can I ask you to please just explain these different terms to us? You hear about MDR TB, XDR TB, TDR TB, and so on.
Okay, thank you so much. That's very important. When we talk about TB, we generally refer to the drug-susceptible tuberculosis.
Right.
But then we do have drug-resistant tuberculosis as well. This is a form of tuberculosis that does not respond to ordinary treatment. You got MDR TB, XDR TB, and TDR. MDR TB is multi-drug resistant tuberculosis. This is a form of tuberculosis where the TB strains are resistant to rifampicin and isoniazid, which are the two most important medicines we use for treatment of drug-susceptible TB or ordinary tuberculosis. So we use rifampicin, isoniazid, ethambutol, and pyrazinamide. Those for the drug-susceptible tuberculosis. But then when the strains are resistant to rifampicin and INH, we call it MDR TB. If you get further resistance to an injectable, be it kanamycin or amikacin, and a fluoroquinolone, could be ofloxacin or levofloxacin, that then becomes XDR TB, extensively drug-resistant tuberculosis. Is the most severe form of tuberculosis. TDR TB, we've seen it in the media. Some academics have talked about it. It's not in the domain of the World Health Organization
so you don't
or
think
the
it
department.
Exists?
It exists, though it hasn't been properly defined. It refers to resistance to all anti-TB treatment. The challenge is we do not test resistance for all existing medicine. That's why I'm saying it's a bit challenging. It means resistance to all the tests available. We don't test all. No country tests all.
How much of a problem is resistance? What is, how much of it do we have?
Resistance is a big problem. We know that we have just about 300,000 patients with tuberculosis in South Africa, and between 2% of them, around 2% will be having resistance. So in each year in South Africa, we treat around 12,000 patients with MDR TB. So it's a very serious problem.
I mean, he mentioned different, types of MDR, XDR, and so on. What do we know about the strains, the specific strains? I mean, are they any different? Is the bacterium that causes MDR TB any different from the one that causes so-called drug-susceptible TB?
So all strains can develop resistance if you take your treatment inappropriately or not correctly. But there are certain strains that are predisposed to developing resistance. And there's one that is spread very extensively in Southeast Asia and is a common cause of MDR-TB in South Africa, and that's called the Beijing strain.
Right.
And that family of strains predisposed to developing resistance. So it is also strongly linked to the type of strain that you're infected with.
But what are the causes then of resistance? Is it, you mentioned if you're not taking your treatment, properly, but some people do take treatment properly and still develop resistance.
Yeah.
What are the reasons?
So if people are completely adherent to their treatment, there may be other reasons for why they do develop resistance, and part of that may be absorption of the drugs may be inadequate. The dosage of the drugs we now think may be a problem. They may not have an adequate number of drugs in the regimen to actually kill that type of TB. And so all these factors contribute to why a treatment regimen may fail.
Yeah. Dr. Jacob, what are we doing about treating resistant TB, MDR, XDR TB?
Yeah, in terms of treating resistance, there are major steps really that one has to follow. Number one, we've had difficulties finding them. Now we find most of them. Over the last
patients
with MDR-TB, diagnostic is very difficult. So you got to find the people before you treat them, and we now treat 2-3 times more than what we treated 4 years ago. So to find the people and early diagnosis, early initiation of treatment is critical. One of the causes of drug resistance is exposure to people who already have the disease. At this stage, we have half the people with MDR-TB, multidrug resistant tuberculosis, who did not have any form of tuberculosis before. So it tells you, really, it underscores what Dr. Lindwem was saying earlier on. Poverty is an issue, overcrowding is an issue. We treat people, we send them back to those areas where they live, and it's a challenge. People get TB several times, so we got to find them, we treat them. We're also introducing new drugs, such as
talk about new drugs.
And
there's an issue around access to drugs to treat MDR-TB. And the main issue there being cost. I mean, at the conference, we believe that there was a march. People are marching against the high cost of treatment for MDR-TB. Your comment?
Yeah, the cost of treating MDR-TB is high. I mean, when we spend roughly 300 rand or 250 to treat 6 months of drug-susceptible TB, you're looking at what, 30,000 rand for 2 years of MDR-TB treatment, and possibly 120,000 for XDR. So it is expensive to treat.
I'd like you to hold your thought there, because I'm going to ask you in the next segment what we're going to do about it going forward. Okay.
Thank you.
So what is the road ahead looking like? Are we on course to eradicate TB by 2030? Then and more after the break. Please stay with us.
Born with malformation of the limbs, David lives his life to the fullest.
I got this, let me try my own. Got on the bed, then start playing soccer in the streets, then like, do this.
He can play soccer, he reads and writes, he is even able to swim, a role model to his peers.
Look at the scripture. It doesn't say I'm a conqueror, it says I'm more than a conqueror.
Join your host Buleng Mulebate on Bupilong every Friday at 17:30.
We live in a digital era, and the number of Africans with mobile phones is rapidly increasing.
Twitter use is predominantly being done on smartphones. This is a very African phenomenon.
Here, there are constantly new innovative ways to make the internet more affordable. With that, we're seeing protests against governments proposing methods to limit access. On Network, we give you information about all of this. We also have new computers, games and robots.
Join Siphumelele Zondi on Network every Sunday at 19:30 CAT.
TB has killed more people in 2014 than any other infectious disease due to a single pathogen, so more deaths than HIV/AIDS, malaria. It's a global problem, so the most affected areas are countries like India, China, South Africa, the sub-Saharan Africa region in general. And it's really, even here in the US, we have about 9,000 cases a year, including some that are multi-drug resistant. So it's truly a global problem. So an effective TB vaccine would really be the ultimate game changer in bringing the TB epidemic under control.
We do already have a vaccine for tuberculosis. It's called BCG. The fact is that most of the world is vaccinated with BCG, and despite this, we have this ongoing spread of TB, and so clearly there's a need for another better vaccine.
It does take a long time to develop a vaccine in general. Typically it takes 10 or more years to develop a vaccine, and TB will certainly not be any easier than that. Despite the fact that it's going to take a long time, right? If we don't start now, it means our children, our grandchildren, generations to come are still going to be fighting this terrible disease that the world is suffering from now, right? Someone dies from TB every 21 seconds, right? 1.5 million lives were lost to TB last year. 9.6 million people got new disease from TB last year. Without a vaccine, we're never going to get this epidemic really under control and eliminate TB as a public health problem.
So, can the vaccine help us eliminate this global and major public health problem? And can this be achieved by 2030? Well, let's find out from our guests in our Johannesburg studio. We're still with Prof. Gavin Churchyard, founder and CEO of the Oram Institute, and we still have Dr. Norbert Njeka from the Department of Health. In our Cape Town studio, we now welcome Kristen Croucher, who's Director for Clinical Operations in an organization called IRIS. Welcome to Health Talk, Kristen.
Thank you, Selo. Good to be here.
Right. Perhaps let's stick with you now and talk about the vaccine. Now, I mean, we're looking towards 2035. How are we doing in terms of developing a more effective TB vaccine?
We've actually come a really long way. 10 years ago, we had only one vaccine candidate in the pipeline, and now we're sitting with 15 candidates. So that is testament to the amazing progress and increased focus on TB vaccine development. We've got 13 of those candidates currently in clinical trials, with one of them being in a phase 2B, which is a proof of preventing actual TB disease study. And that's very exciting for the field.
But how can this be accelerated going forward? Are there any challenges around, research in vaccines and so on?
There actually are. So there are a number of challenges. Number one, we don't have what's called a correlate of risk or a correlate of protection. So we don't yet know what we're looking for in the immune system that would correlate with somebody being protected from TB. We also don't have a good animal model. So in research and development, you need to be able to test a new product in an animal study first, be able to see whether you're getting the right kind of immune response and hopefully also protection in the animal model, and then be able to push different candidates through faster. So those are two of our really big challenges at the moment in TB vaccine development. But we've had some really good progress, especially in this year. We've seen some of the new candidate TB vaccines being able to show better protection in some animal models over and above BCG's protection. And also we've done a natural transmission study, so from one animal naturally transmitting TB to another animal. And if we can validate that result and see how we could really test a vaccine in an animal environment with natural transmission of TB, if we can do that, we'll really be able to move the field forward faster. And then lastly, we're working on what's called a human challenge model. When you do vaccine development, if you are able to infect a human with the disease that you're trying to protect them from in a way that doesn't make them sick, you can push a lot more candidate vaccines through faster, because you can very quickly see if you can help the body's immune system clear the infection. At the moment, we can't do that in TB, because even a small amount of active TB will potentially make somebody sick. So we're working on a human challenge model, which is a way that we deactivate the TB enough to not make somebody sick, but to still be able to check or test vaccine candidates in the human. So if we can do that, that will really be a game changer for TB vaccine development and accelerate the pathway forwards.
Now, looking forward now, I mean, we've got the NTB strategy looking, towards 2030. With your involvement and contribution by way of a vaccine, do you think we'll be able to eradicate TB by 2030?
We won't eradicate TB by 2030. The Stop TB Partnership, I think, targets 2015 for TB eradication entirely, but we're looking to decrease it significantly. And we've done mathematical modeling that's actually shown us how we can get the most impact by 2030. And that's what's brought us from looking for a pediatric vaccine to targeting an adolescent vaccine. This modeling showed that if we were to be able to get a pediatric vaccine into the clinic by 2025, for example, we wouldn't have as great an impact as if we get an adolescent vaccine. If we get an adolescent vaccine by 2025, we could avert 30 to 35 million more cases of TB by 2035 than if we only had a pediatric vaccine. So we're looking at getting a vaccine at least in late stage development by 2025.
Okay. Prof. Cheche, let me invite and comment from you now. I mean, we've heard about vaccine development. Any work done in new treatment methods going forward?
Yeah, so there's been, in all the new tools, lots of development with regard to development of new drugs. Again, there is similarly a reasonably healthy pipeline. We have 2 new drugs that we are now rolling out, bedaquiline and laminate, and South Africa has been the forerunner of the bedaquiline rollout. And there are other drugs that we currently are evaluating. That pipeline, however, is probably not as strong as what it needs to be to substantially reduce the duration of treatment and to develop a regimen that will be able to treat any form of TB, regardless of whether it's resistant to the old drugs or not. And so that work is in progress. We're now looking at using other existing drugs, not TB drugs, other drugs that we used to treat hypertension with, diabetes with, cancer drugs, that when we combine with the TB drugs, makes it easier for the TB drugs to work and kill the TB bug.
What about combination drugs? I mean, we've seen, we clearly agree that there's an adherence problem, and one of the problems is having to take, a handful of tablets. And we've seen the success that a combination drug in HIV, ARV therapy, has had.
Yes. So there are fixed dose combination treatment already in existence, certainly for the first line regimens that we use to treat drug susceptible TB. Clearly very important for ensuring adherence. We still have to get to a regimen for MDR or XDR TB that we can put into a fixed dose combination. But that's in progress. The other thing from a drug perspective is looking at pediatric formulations. So there's been some new developments on that as well.
Okay. Dr. Njeka, earlier I asked you about, how we're going to ensure that the cost of these drugs to treat MDR TB, is affordable. What work is done in that regard?
Yeah, in terms of access, of course, cost is very important. But the first thing that we've done as the Department of Health has been to increase the number of treatment initiation sites. 4 years ago, we're sitting at 18 sites in the whole country, 18 or 19 in the whole country. We now have close to 600 sites where patients are being initiated. And if you look at the ratio, 12,000 with 600 sites, you're looking at 30 patients probably in a year, and that's very much reasonable, but we want to do more. In terms of cost, our patients do not pay for drugs. TB treatment is free. MDR TB treatment is free. There's cost to government. We have bedaquiline at a reduced price of 9,950 for 6 months period. And that's for a few patients that are on bedaquiline, just 1,000 of them. But for the bulk of our patients, our MDR TB regimen will cost government approximately 1,200 Rand a month for treatment in injectable phase. And then after 6 months, when they're on continuation phase, it's around 900 Rand treatment. That's what makes it 25,000 Rand on average medicine cost. Of course, for your XDR, it is more expensive. The challenge with resistance is that it occurs by chance. It becomes even difficult to start packaging regimen, put FDCs, because it occurs by chance. And you go to align the treatment with the resistance within a particular patient, and patients are unique. So patient-centered care around that is critical, but then the challenge is that you need various combinations for various patients, and it poses a challenge.
Okay. Let's get back to the NTB campaign.
Yes.
I mean, the strategy is to at least significantly reduce, it is about 95%, as it were,
yes,
by 2030.
Yes.
Let's look at home now. What targets are we setting ourselves? I mean, if you look at this TB strategy, it's got every 5 years, you know,
yes,
milestones,
yes,
every 5 years where you can, you know, look at progress and so on.
Yes.
We had the National Strategic Plan that looked at 2012 to 2016.
Yes.
How are we doing in that regard? What targets are we setting ourselves?
Yeah, the way forward back home really is we put a DIP process, district implementation process, whereby we're taking these targets lower to that level. We want to screen 90% of all vulnerable or high-risk groups, test 90% of these people that are, you know, have signs of tuberculosis.
But how are we intensifying the screening processes?
The screening process, like Dr. Lindu and Vusi said earlier on, that are big numbers. All people that attend our healthcare facilities should be offered screening. That is going on. It is not yet what we want it to be. But people who attend healthcare facilities are screened. And I think the state president also announced during the State of the Nation address, he spoke about the active, this massive TB screening exercise that we embark on. So there are a lot of effort in our healthcare facilities, in correctional service facilities, in creches, and the Deputy President launched this in a village in Northwest during the World TB Day. So we going through like I said, we got to find TB and treat 90% of them, at least could be 100, but if you treat at least 90% and achieve 90% success rate, then we'll be achieving. But we will not, by the way, we've had experts who've looked at, who've done our TB investment case. They told us will not really eliminate by 2030, but it will decrease significantly. But elimination, as WHO is talking about now, means less than 10 people per 100,000 population.
So are you saying we'll never...
So we will go closer to that,
Yeah.
but it will need combination of effort to go closer to that, but it won't be like elimination to zero.
Let me get your last thoughts, Prof. Chesh. We've run out of time, but I'm sure I can give you 30 seconds more. What do you think needs to be done in order to help us achieve or get as close as possible to these targets?
So South Africa is the one country where if we scale up rapidly, high coverage, the combination treatment and prevention strategy that Norbert was talking about, we have the potential to actually meet the NTB targets for South Africa by 2035.
All right. Okay, I'll tell you what. I'll arrange a show like this in 5 years' time,
and we'll
so we can
talk
have a
again.
look. All right. Unfortunately, that's where we end it today, folks. And thank you for all the guests: Prof. Gavin Churchyard, CEO of Oram Institute; Dr. Njeka, Director TB, MDR TB within the National Department of Health; and of course, Dr. Lindiwe Mvusi, Director TB Control and Management Cluster in the Department of Health, and Christine Krasher, Director, Clinical Operations of IRAS. Thank you so much for your contribution, folks. So on that note, that we come to the end of our show today. You can join us again next week on SABC News. A reminder to please share your views and comments with us on our Facebook page, SABC Health Talk. And you can follow us, of course, on Twitter at SABC Health Talk. Remember that you can watch a repeat of this show on Tuesday morning at 5 a.m. or go to SABC YouTube link to get all our previous shows. I'm Dr. Silla Mudau. Thank you so much for watching, and do take care.